I signed the death certificate at 2:14 a.m., but nothing about his body told me he was actually gone. My name is Dr. Allison Greer. I'm 46 years old, and until recently, I worked as a hospice physician at Silver Willows Hospice Center, just outside Salem, Oregon. Hospice is supposed to be predictable. Not easy, not painless, but predictable. Patients arrive with clear diagnoses, clear trajectories, and clear expectations. We don't cure. We manage comfort. We guide families. We wait. That night was supposed to be no different. Silver Willows is quiet by design. Low lighting, soft monitors. No overhead pages unless someone is actively crashing, which almost never happens in hospice. The loudest sounds are oxygen concentrators and the squeak of nurses' shoes during night rounds. I was on my third overnight shift that week, slightly under-caffeinated, reviewing charts that all said the same thing in different words: end stage, comfort measures, only no escalation. At 9:37 p.m., a transport van from the hospital arrived with a new admission. Samuel Crow, 62, end-stage pulmonary fibrosis, transferred from a regional hospital after pulmonology and critical care agreed there was nothing more to offer. Prognosis days, maybe a week if he was lucky. The hospital labs were already in the chart. Imaging done. Decisions made. My role was simple: meet him, adjust comfort meds, make sure the family understood what was coming. I skimmed the chart while the nurses settled him into room 12. Oxygen via nasal cannula, morphine as needed, no IV drips, no telemetry beyond basic monitoring. Hospice doesn't chase numbers. We watch people. When I walked into his room, the first thing I noticed was how calm he looked. Not sedated calm, not exhausted calm, just neutral. His breathing was shallow but steady. Oxygen saturation hovered at 94%, which was better than I expected given his lung function. He opened his eyes when I introduced myself. No confusion, no fear. He nodded when I explained where he was. "How are you feeling?" I asked. "Fine," he said. Patients don't say that. They say tired. They say short of breath. They say scared. Fine is not a word I hear from people who've just been told they're dying. I chalked it up to denial and moved on. During my first check later that night, one of the nurses mentioned she'd had trouble getting a manual pulse. Automatic cuff worked. Blood pressure was fine. Heart rate normal on the monitor. Sometimes peripheral circulation is poor in these patients. Cold hands, dehydration, it happens. Still, I went in myself. I wrapped the cuff around his arm and reached for his wrist. Nothing. I adjusted my fingers. Still nothing. I checked the other wrist. Same result. The monitor showed a steady heart rate in the low 80s. Blood pressure, red, clean. Skin color was good, warm, pink. I listened to his chest. Heart sounds were there, but faint. Not muffled, not irregular, just quiet. I told myself it was nothing. Hospice medicine teaches you not to overreact. We don't chase every anomaly because most of them don't change the outcome. I documented difficult to palpate peripheral pulse and moved on. Around midnight, I passed his room again. He was awake, staring at the ceiling, breathing unchanged. No distress. I asked if he needed anything. "No," he said. Then after a pause, "You're waiting." "Waiting for what?" I asked. "For me," he said, "to stop." The way he said it wasn't accusatory, it wasn't dramatic, it sounded like someone stating a schedule. That was the moment I stopped walking. I've heard patients talk about death in every possible way. Bargaining, anger, humor, fear. What I hadn't heard was someone describing it like an appointment everyone else had already booked. If this part caught your attention, take a second and leave a comment. I read them. And if you want to hear how this actually unfolded, subscribe so you don't miss what comes next. I smiled politely and gave the standard hospice response. Reassurance, presence, nothing concrete. When I stepped back into the hallway, the nurse on duty gave me a look. She'd heard it too. At 10 a.m., his monitor alarmed briefly. Not a critical alert, just a momentary dip that corrected itself. I went back in. Same findings, stable vitals, no visible distress, no pulse at the wrist. By 2 a.m., his breathing slowed. Not dramatically, just enough that the nurse called me in. We watched together, counted respirations, waited for the change we both expected. It didn't come. At 2:14 a.m., there was no breath, no chest movement, no response to voice. I listened. Nothing. I checked for a carotid pulse, longer than protocol required. Nothing. I pronounced him dead. I signed the certificate. And then I stood there longer than I should have because something about the room felt wrong. Not eerie, not dramatic, just incomplete. His skin was still warm. His color hadn't shifted. The room didn't feel like it usually does after someone dies. I told myself that bodies take time, that hospice isn't exact, that medicine isn't always cinematic. I left the room. By morning, the chart was closed. The system moved on. Another patient admitted, another bed filled. That's how hospice works. It has to. But when I came back for my next shift, I went straight to room 12. Not because I expected anything to be there, because I couldn't shake the feeling that I'd signed something I didn't fully understand. I stopped outside room 12 and checked the door sign before I went in, even though I already knew what it would say. Empty. The bed had been stripped and remade. Fresh sheets, clean pillowcase, the oxygen tubing coiled neatly against the wall. It looked exactly like every other room that had done its job overnight. I stood there longer than necessary, staring at the spot where Samuel Crow had been less than 12 hours earlier, waiting for the feeling I usually get after a death to arrive. It didn't. I walked back to the nurse's station and opened his chart again. Time of death, cause signed, closed. Everything was clean, too clean. Hospice charts are meant to be simple, but this one felt aggressively tidy, like the system had hurried to put distance between itself and the details. I scrolled back to the hospital records he'd arrived with. Labs from 2 days before transfer, arterial blood gases, metabolic panel, lactate 0.4, low but not impossible. Borderline strange, but not a red flag anyone would chase in a patient who was already being discharged to die. The pulmonology note focused on fibrosis, oxygen dependence, declining function. Nothing about circulation, nothing about perfusion, nothing that explained why I couldn't feel a pulse. Karen Muldoon, the charge nurse, slid into the chair beside me with a cup of coffee I hadn't asked for. She'd been doing hospice nursing longer than I'd been a doctor. If something bothered her, it was worth listening to. I checked him again after you left, she said quietly. Pulse, I asked. She shook her head. Same thing. Monitor looked fine, cuff worked, my fingers didn't. We sat there for a moment, neither of us saying what we were thinking. Hospice doesn't reward suspicion. It rewards acceptance. You learn quickly which questions don't change outcomes and which ones just make everyone uncomfortable. I documented it, she added. Didn't make a big deal. I know, I said. That's what you're supposed to do. It bothered me that I meant it. The rest of the morning passed the way hospice mornings always do. Family meetings, medication adjustments, quiet rooms with televisions turned down low. I did my job. I smiled when appropriate. I explained things I had explained 100 times before, but my attention kept drifting back to details that shouldn't have mattered. The warmth of his skin, the lack of cyanosis, the way his oxygen saturation never dipped into the numbers I usually associate with someone whose lungs were failing. None of it was dramatic. None of it was enough to justify alarm. It just didn't add up cleanly. Just before noon, a new admission was announced. Eleanor Whitman, 74, advanced heart failure, transferred from a different hospital across town. Different diagnosis, different referral team, same destination. When I met her, the similarities were subtle but immediate. Calm effect, clear speech, no visible distress. Her chart showed repeated admissions for decompensation, fluid overload, arrhythmias. The hospital had done what hospitals do, diuresed, adjusted meds, escalated until escalation stopped making sense. Her nurse called me in an hour later. "Can you come look at this?" she asked. Eleanor's blood pressure cuff read normal. Her heart rate was steady on the monitor. When I reached for her wrist, my fingers found nothing. I checked again, then her other arm, then her neck. Her pulse was faint enough to be more theory than sensation. I listened to her chest. Heart sounds were present but distant, like they were happening behind a closed door. She watched me with mild curiosity, not concern. "Is something wrong?" she asked. "No," I said automatically. "I'm just checking." That was a lie. Something was wrong. I just didn't have language for it yet. Back at the station, I pulled up Eleanor's hospital labs. Lactate 0.5. Still low, still within a range no one would question given everything else going on. Renal function preserved, electrolytes unremarkable, the kind of labs you'd call reassuring if you weren't paying too much attention. Karen leaned over my shoulder. "That's two," she said. "Different diseases," I replied. "Different hospitals. Same weird," she said. She wasn't wrong. I spent the afternoon doing what medicine teaches you to do when something doesn't make sense. I tried to explain it away. Poor peripheral circulation, measurement error, end-of-life physiology behaving unpredictably. Hospice patients don't read textbooks. I've said that myself. By evening rounds, Eleanor's pulse was even harder to detect. Her skin was still warm, her color still good. She was comfortable chatting briefly with a volunteer about her dog. I stood there longer than I should have, stethoscope pressed to her chest, listening for reassurance that didn't come. The monitor didn't care. It kept tracing neat little lines, confident in its interpretation of reality. As I walked out, Eleanor called after me. "You're doing that thing again," she said. I turned. "What thing?" "Listening like you don't trust what you're hearing," she said. "Doctors do that when the numbers stop agreeing with them." I didn't respond. I wrote my notes carefully that night. Neutral language, observational, no conclusions, just enough detail to be honest without being provocative. Hospice charts don't invite philosophy. Still, as the unit quieted and lights dimmed, I found myself watching monitors longer than necessary, waiting for something obvious to justify the unease I couldn't shake. Nothing happened, and that somehow made it worse. I leaned against the counter and stared at the monitor outside Eleanor's room longer than I meant to, long enough for the numbers to blur into something abstract instead of reassuring. Hospice medicine trains you to tolerate uncertainty. It also trains you to know when not to poke at it. I reminded myself of that as I finally turned away and forced my attention back to the stack of charts waiting for signatures. There was nothing actionable here, no intervention to offer, no escalation that made sense. My job was comfort, not curiosity. Still, I found myself opening Samuel Crow's chart again, even though it was already archived. I reread the hospital notes more carefully this time, not looking for dramatic red flags, but for small omissions. Anything about vascular disease, neuropathy, peripheral artery issues, there was nothing. His circulation had never been mentioned as a problem because, according to every recorded metric, it wasn't one. I told myself that end-stage illness can do strange things, that bodies don't always decline in neat textbook patterns, that sometimes things line up just enough to look wrong when they aren't. That explanation worked until it didn't. During night rounds, Rachel Bennett, one of our newer nurses, stopped me outside Eleanor's room. She looked uncomfortable the way clinicians do when they're worried they're about to say something that sounds foolish. "Can I ask you something without it going in the chart?" she said. I nodded. "Have you ever seen a patient this stable, this close to the end?" she asked. "I mean clinically stable." I knew what she meant. Eleanor should have been struggling more, short of breath, hypotensive, cool to the touch. Instead, she looked like someone waiting for a ride that was running late. "I've seen variation," I said. "A lot of it." Rachel hesitated. "I can't get a pulse on her," she said. "I checked 3 times. I know," I replied. That was the first time I said it out loud without softening it. I went back into Eleanor's room with her, checked myself. Same result. Monitors unchanged. No distress, no explanation that felt satisfying. I documented again, careful with my wording. Peripheral pulses difficult to palpate. Not absent. Difficult. Medicine loves qualifiers. They give you room to retreat later. Around 2 a.m., Eleanor's breathing pattern shifted slightly. Slower. More spaced out. Rachel called me in. We watched together, counting respirations, waiting for the familiar cascade that usually follows. It didn't come. Eleanor opened her eyes and looked at us both. "You're checking me like you're not sure what you're looking for," she said calmly. Rachel froze. I smiled the way doctors smile when patients say something uncomfortable but perceptive. "We're just making sure you're comfortable," I said. "I am," she replied. "You're the ones who seem tense." That comment followed me back to the station. By morning, Eleanor was unchanged. No crisis, no decline, just a quiet persistence that didn't match her diagnosis. I finished my shift and drove home through fog that made the highway lights smear into long yellow streaks. I replayed the night in my head, not dramatically, just clinically, as if there were a missing data point I hadn't noticed yet. Sleep didn't come easily. When I returned that evening, Eleanor was still there, still stable, still without a palpable pulse, still with monitors that insisted everything was normal. I checked her labs from the hospital again. Nothing new, nothing evolving, no trend that explained the disconnect between what I expected and what I was seeing. I asked Karen if she'd ever encountered anything like this. "Not like this," she said. "But hospice has a way of showing you the edges of things." "What edges?" I asked. She shrugged. "Where the rules stop being helpful." That wasn't an answer. It wasn't meant to be. I considered calling the hospital cardiologist who'd signed Eleanor's discharge summary, then dismissed the idea. What would I say? That a hospice patient was behaving oddly, that monitors were doing their job while my hands weren't. Hospice doesn't invite outside opinions unless there's a clear problem to solve. There wasn't one. Not officially. That night, I paid closer attention to Eleanor's skin. Capillary refill was normal. Warmth was even. No mottling. No cyanosis. These were details I'd learned to stop focusing on years ago because they usually tell the same story as everything else. This time they didn't. I found myself standing in the hallway again, watching the monitor trace its calm little rhythm, wondering which part of my assessment I trusted more, the machine or my own senses. Medicine trains you to believe that data is king, but it also teaches you how easily data can lull you into complacency if you stop asking where it comes from. At 3:30 a.m., Eleanor's heart rate dipped briefly, then corrected. The monitor beeped once, almost apologetically. I stepped into the room. Same findings, same calm, same absence of anything dramatic enough to justify action. I realized then that I was waiting, not for her to die, but for something to break the stalemate, a symptom, a change, anything that would force the situation into a familiar shape. Nothing did. When morning came, Eleanor was still alive, still comfortable, still confusing. I handed off to the day physician with a report that felt incomplete no matter how carefully I phrased it. Keep an eye on her circulation, I said, hearing how vague it sounded. All day I thought about Samuel Crowe, about how quickly his room had been reset, about how easily the system had absorbed his death and moved on, about how little room hospice leaves for questions that don't alter the plan. By the time I came back for my next overnight, I realized something I hadn't wanted to admit before. I wasn't trying to understand these patients anymore. I was trying to decide how much confusion I was willing to tolerate before it started to change how I practiced medicine. I reached for the stethoscope outside Eleanor's room and realized my hand was already there, like it had been waiting ahead of me. She was awake, sitting slightly upright, watching the early morning news without sound. The screen showed a weather map she wasn't looking at. Her breathing was steady, her color unchanged. I greeted her, checked her comfort level, and moved straight to the exam without small talk. Pulse. Nothing. I checked again, slower this time, pressing just enough to feel tissue without collapsing vessels. Still nothing. I listened to her chest. Heart sounds were present but distant, unchanged from the night before. The monitor continued to insist on a steady rhythm. I documented and stepped back into the hallway where Karen was already waiting. Same, she asked. Same, I said. She nodded once. No surprise. That bothered me more than disagreement would have. By noon, Eleanor had been awake for hours without any sign of decline. The day nurse mentioned she'd eaten a few spoonfuls of soup, not because she was hungry, she said, but because she didn't see the harm. That comment stuck with me. Most patients at this stage don't bother with food. Their bodies tell them when it's time to stop. Eleanor's body wasn't sending those signals. Later that afternoon, a third chart crossed my desk for review. Not an admission, a consult note from earlier in the week that I'd skimmed and forgotten. A patient discharged from the hospital to hospice, but diverted to another facility due to bed availability. Similar age, different diagnosis, same calm language in the discharge summary. Stable, comfortable, appropriate for hospice. I read it twice. This wasn't proof of anything. Hospice patients share traits by definition. Still, something about the wording felt familiar. Too clean, too confident. I went back to Eleanor's room as the unit quieted for the evening. She was watching the door when I entered, like she'd been expecting me. "You're back," she said. "Yes," I replied. "Just checking on you." She smiled. "You've been checking a lot. That's my job." She considered that. "It looks tiring." I didn't answer. I checked her vitals again. Nothing new, nothing helpful. "Do you know what time it is?" she asked. "A little after 8. She nodded. "People think dying happens at a specific time. Like it's a train you can watch coming." I paused. "Sometimes it does. And sometimes," she said, "the schedule is wrong." That was the second time a patient had framed it that way. Not fear, not denial, scheduling. I left the room with a tightness in my chest that had nothing to do with anxiety and everything to do with recognition. This wasn't about one patient behaving oddly. This was about a shared rhythm that didn't match what we expected to hear. Around 10:30 p.m., Karen called me into the medication room. She'd pulled a few charts, not because policy required it, but because she trusted her instincts. "Look at these," she said, sliding them across the counter. 2 hospice discharges from the past month. Both had passed within 48 hours of admission. Both were unremarkable on paper. Both had minimal documentation about circulation beyond automated readings. No mention of pulse or irregularities, no flags, no questions raised. "We're not supposed to look for patterns like this," she said. "Hospice isn't epidemiology." "I know," I said. "But you see it," she said. I did, not clearly, not conclusively, but enough that ignoring it felt like a choice instead of a default. Back on the floor, Eleanor's monitor alarmed softly. Not an emergency, just a brief drop that corrected itself. I entered the room. Same calm, same warmth, same absence of the physical signs I'd been trained to rely on. I checked her carotid pulse again. Nothing. I checked longer than protocol required, counting slowly in my head. Still nothing. Her blood pressure cuff cycled and displayed a normal reading. I felt the dissonance settle into something heavier. Not fear, responsibility. I stepped out and pulled up her chart, reading every note written since admission. Each entry was technically accurate. Each one avoided interpretation. Together, they formed a picture that felt incomplete by design. Rachel passed by and stopped. "She's still okay?" she asked. "Yes," I said. Rachel hesitated. "That's what's weird, isn't it?" I nodded. We stood there longer than necessary, listening to the unit breathe. Oxygen machines, distant footsteps, a call light down the hall, normal sounds that usually ground me. That night I started writing differently. Not dramatically, not alarmist, just more precisely. Times, sensations, what my hands felt and didn't feel. I avoided conclusions, but I stopped smoothing over uncertainty. Around 1:00 a.m., Eleanor slept. Her breathing slowed but stayed even. No gasping, no struggle. I sat at the desk and stared at the hallway, thinking about Samuel Crowe, about how quickly his case had closed, about how easy it had been to tell myself it was an isolated oddity. I wasn't thinking that anymore. At 3 a.m., Eleanor opened her eyes and looked directly at me from across the hall. I hadn't realized she was awake. "You're counting again," she said quietly. "Yes," I replied. "Are you counting for me?" she asked, "or for you?" I didn't answer. I checked her vitals one more time. Nothing changed, nothing resolved. By morning, Eleanor was still alive, still comfortable, still defying the quiet timeline her diagnosis suggested. I handed off to the day team with careful language and a growing awareness that something had shifted. This wasn't vigilance anymore. It was recognition. I rubbed my eyes at the nurse's station and realized I'd been staring at the same line in Eleanor's chart for almost a full minute without reading it. Hospice documentation is built for efficiency, not investigation. You chart comfort. You chart changes that require medication adjustments. You chart death. Everything else is background noise. I knew that when I took the job. I'd defended that structure more times than I could count. Now, reading through Eleanor's notes, I felt the edges of that design pressing in. Nothing in the system encouraged anyone to slow down and ask why something felt off if it didn't alter the plan. During morning rounds, the administrator stopped by to check census numbers. Beds were full, admissions steady, families mostly satisfied. This was considered a good week. She comfortable? He asked, nodding toward Eleanor's room. Yes, I said. That was all he needed. Later, I raised the issue casually with another physician on service, careful not to frame it as concern. I mentioned difficulty palpating pulses. Stable monitors. Odd, but probably nothing. He nodded unconcerned. Hospice physiology can be strange, he said. End of life doesn't follow rules. That phrase landed harder than it should have. End of life doesn't follow rules was exactly the problem. We relied on those rules to know when to act and when to let go. Without them, everything became subjective. Everything became a judgment call no one wanted to own. By evening, Eleanor's vitals remained unchanged. Her blood pressure cuff continued to produce clean readings. Her heart rate stayed within a range that reassured machines. My hands continued to find nothing where a pulse should be. I asked Karen if anyone had flagged similar issues recently. Not formally, she said. And formally is what matters. She wasn't being dismissive. She was being honest. In hospice, patterns don't trigger alerts. Crashes do, pain does, agitation does. Quiet inconsistencies don't rise to the level of concern because they don't demand action. They just sit there unaddressed until someone decides they matter. I found myself standing in the supply room longer than necessary, listening to the hum of the refrigerator and thinking about how easily a system can function while missing something essential. Silver Willows wasn't negligent, it was optimized. And optimization leaves very little room for anomalies. That night, Eleanor asked for ice water. I brought it myself. She took a sip, set the cup down, and looked at me. You look frustrated, she said. I'm fine, I replied. She smiled slightly. That's what you said yesterday. I checked her wrist again out of habit. Nothing. Does it bother you? She asked when things don't behave the way you expect. Yes, I said before I could stop myself. She nodded as if that answer confirmed something. Back at the desk, I reviewed the previous month's discharges again, this time paying attention to how quickly charts closed after death. The timestamps were tight, efficient. There was no space between pronouncement and completion, no pause for uncertainty. The system rewarded closure. I understood why. Families needed answers, beds needed to turn over, staff needed to move on. Lingering questions don't fit into workflows. Still, I couldn't shake the sense that we were smoothing over something important because it didn't fit neatly into our categories. Rachel joined me during her break, lowering her voice. I checked Eleanor again, she said. Same thing. Did you document it? I asked. She hesitated. I wrote what the monitor showed. I didn't correct her. I couldn't blame her. Charting uncertainty feels risky. It suggests doubt. Doubt implies responsibility. As the night deepened, the unit settled into its usual rhythm. Lights dimmed. Call bells quieted. A television murmured somewhere down the hall. Normalcy pressed in, trying to reclaim the space. I went back into Eleanor's room and stood there, hands at my sides, resisting the urge to check her pulse again. I already knew what I wouldn't find. Her breathing slowed slightly. Not enough to worry anyone, just enough to draw attention. I watched, waiting for the familiar signs that usually follow. They didn't arrive. I stepped into the hallway and leaned against the wall, feeling the weight of the decision I hadn't made yet. Whether to push, whether to question, whether to let the system do what it was designed to do. Hospice teaches you to respect the natural course of dying. It doesn't teach you what to do when the course itself feels misdrawn. At 2:40 a.m., Eleanor's monitor alarmed briefly again, a soft chime, nothing urgent. I silenced it and watched the line settle back into place. The machine was satisfied. I wasn't. I opened her chart and added another note. Precise, neutral, no conclusions, just observations that refused to be smoothed away. I didn't know if anyone would read them closely. I only knew I couldn't keep pretending everything fit. As I closed the chart, I realized something uncomfortable. The system wasn't failing. It was working exactly as intended. I pressed the stethoscope against Eleanor's chest and felt my shoulders tense before my ears registered what was missing. Silence. I shifted the diaphragm slightly, listening again, adjusting my position, the way you do when you assume the problem is you. Still nothing. No lub-dub. No faint thump, no irregular flutter hiding under lung sounds, just the quiet hiss of oxygen and the soft whir of the monitor behind me. I glanced at the screen. Heart rate 78, rhythm steady, blood pressure cycling normally. The machine had no idea anything was wrong. I listened again, longer this time. Still nothing. Eleanor's eyes were open. She was watching my face, not the ceiling, not the television. Me. Is it supposed to be that quiet? She asked. I didn't answer right away. I moved the stethoscope to another position. Lower, more lateral. Same result. Silence. It's fine, I said, finally aware of how automatic it sounded. I stepped out into the hallway and closed the door softly behind me. Karen was already there. She'd been watching the monitor too. You hear it? She asked. No, I said. She didn't ask me to clarify. We went back in together. She listened herself. Same silence. She checked Eleanor's wrist. Nothing. Carotid. Nothing. The blood pressure cuff inflated and deflated, displaying numbers that belonged to a living person. Rachel joined us, drawn by the stillness in the room. She listened, her brow furrowed. I don't hear anything, she said. Eleanor remained comfortable, breathing evenly, skin warm, color good. No distress, no confusion, no agitation. This doesn't make sense, Rachel said quietly. No, I agreed. It doesn't. I forced myself to slow down. Panic is contagious in medical settings, and hospice magnifies it. I checked everything methodically. Respirations, pupils, response to voice, all appropriate. I reminded myself that monitors don't lie, that stethoscopes can, that end-stage physiology can dampen sounds, but my training kept pushing back. A heart that produces enough pressure to generate a blood pressure should make noise. It should transmit something. I stepped into the hallway and picked up the phone to call the on-call medical director, then set it back down. What would I say? That a hospice patient was alive without audible heart sounds. That the machines disagreed with my senses. This wasn't an emergency in any conventional sense. I went back into Eleanor's room and sat in the chair beside her bed. She looked at me calmly. You're listening for something that isn't there, she said. I'm listening to make sure you're okay, I replied. She nodded. That's what you need to tell yourself. The monitor beeped softly as if to punctuate the moment. I checked it again. Still stable, still unconcerned. Across the hall, another patient coughed. A call light flickered on. Normal hospice sounds intruding on something that felt anything but normal. I stood and listened one more time, not because I expected a different result, but because I needed to be certain. Silence. I documented exactly what I found. No interpretation, no speculation, just the absence. My fingers hovered over the keyboard longer than usual before I finished the note. Around 1:30 a.m., Eleanor shifted slightly in bed. Her breathing slowed, then settled. The monitor continued its calm trace. I watched her chest rise and fall, syncing my own breathing to it without realizing. Karen leaned against the wall beside me. If this were a hospital, she said, we'd be running tests right now. Yes, I said, and here she asked. Here we watch, I replied. She nodded. That's the rule. The problem was that watching wasn't giving me any answers. I checked Eleanor again at 2 a.m. Same findings, no heart sounds, no pulse, stable vitals. She was still responsive, still comfortable, still very much present. At 2:18 a.m., her breathing paused for longer than before. Not dramatically, just long enough for me to count past where I usually stop. I leaned forward, watched, waited. She took another breath. Rachel exhaled behind me. This feels wrong, she said. Yes, I replied. It does. I realized then that I wasn't afraid she would die. I was afraid she wouldn't do it the way I understood. At 3 a.m., Eleanor closed her eyes and slept. Her breathing remained steady. The monitor stayed satisfied. I listened again out of habit more than hope. Silence. I stepped out of the room and stood at the nurse's station, staring at the hallway. I thought about Samuel Crowe, about how similar this felt now that I was paying attention, about how I trusted the process to handle whatever didn't fit. Hospice is built on acceptance, but acceptance requires understanding what you're accepting. By 4 a.m., my notes were meticulous, times, observations, what I heard, what I didn't. I avoided conclusions, but I stopped protecting the narrative. At 4:37 a.m., Eleanor's blood pressure cycled again. Normal. I almost laughed at the absurdity of it. The machine was relentless in its confidence. When dawn light began to creep through the windows, Eleanor opened her eyes again. You're still here, she said. Yes, I replied. She smiled faintly. Good. I checked her one more time. Same findings, same silence, same contradiction. As the day staff began to arrive, the unit slowly woke up around us. Conversations, coffee, clipboards, the machinery of care restarting itself. I gave report carefully, factually, without drama, without reassurance. When I finally stepped away from Eleanor's room, I felt something settle into place. Not fear, certainty. Whatever was happening here wasn't going to announce itself with alarms or crashes. It was going to sit quietly inside the rules we trusted and wait for us to decide whether we were willing to notice. I placed 2 fingers at Eleanor's neck and counted longer than I ever had before. Not because I expected to feel something, but because stopping felt like a decision I wasn't ready to make. Nothing. Her chest was still, no rise, no fall. I watched closely for the small movements you learn to recognize over years of practice, the ones that can fool you into thinking breathing has stopped when it hasn't. There were none. I leaned in, listening for airflow, then for heart sounds I already knew wouldn't be there. Silence. The monitor still showed a rhythm, but it was slowing now, drifting in a way that suggested a system losing interest rather than failing. Blood pressure cycled one last time and displayed numbers that looked almost reasonable before the screen went blank. I looked at the clock on the wall. 2:58 a.m. I pronounced her dead. The words came out steady. My voice didn't crack. Years of training took over, guiding me through the steps that follow a moment like this. I checked pupils, fixed. I noted the time. I turned off the monitor. Karen stood beside me, arms folded, eyes on Eleanor's face. Rachel hovered near the door, silent. We waited. Usually something changes quickly after death. Color shifts, skin cools, muscles relax in a way that's unmistakable. It doesn't happen all at once, but it starts. The body gives you feedback that confirms what you've just declared. Eleanor didn't. Her skin remained warm. Her color barely changed. I touched her forearm again, expecting at least a subtle difference. Nothing. This can take time. I said more to myself than anyone else. Karen nodded, but her expression didn't change. She'd been doing this long enough to know what time usually looks like. We completed post-mortem care the way hospice requires. Gently, respectfully, efficiently. Eleanor's body didn't resist, but it didn't respond the way I expected either. There was no stiffness yet, no gravity pulling blood into dependent areas. I checked again, aware of how compulsive it had become. Still warm, I stepped out to complete the paperwork. Death certificates don't ask for nuance. They want a cause, a time, a signature. I filled in the blanks with information that was technically correct and emotionally unsatisfying. Heart failure. Time of death, 2:58 a.m. My hand hesitated before I signed. Not because I doubted the criteria, because I doubted the meaning. I signed anyway. The printer whirred softly. The system accepted the input without question. When I returned to Eleanor's room, Karen was standing by the bed watching her face. Anything I asked? She shook her head. Rachel glanced at the clock. It's been over 20 minutes, she said. I knew what she was implying. Rigor mortis doesn't set in immediately, but there are early changes. There's a sequence you learn to anticipate. This body wasn't following it. We documented what we saw without commentary. Warm skin, no immediate signs of lividity, no rigidity. It wasn't wrong exactly. It was just incomplete. By the time the funeral home was notified, dawn was beginning to lighten the windows. The unit felt suspended in that strange in-between state where night staff are still working and day staff haven't fully arrived. Conversations were hushed. Movement slowed. I checked Eleanor one last time before leaving the room. Not for vitals, for reassurance that what I'd done made sense. Her skin was still warm. I stepped back and closed the door. Later that morning, I returned to the unit to finish documentation and handoff. Eleanor's room was quiet, the bed still occupied, the body unchanged. I stood there with Karen, neither of us speaking. This isn't how it usually goes, she said finally. No, I replied. But it happens sometimes, she added, offering a lifeline. Sometimes I agreed. The funeral home arrived just before noon. 2 men in dark jackets, professional and polite. They did their work efficiently without commentary. They didn't comment on the warmth. They didn't comment on the absence of stiffness. They followed protocol the same way we had. When they wheeled Eleanor out the hallway, barely noticed. Another quiet exit, another bed soon to be filled. I went back to the nurse's station and opened the chart again. Everything was complete, clean, closed. The timestamps lined up neatly. No gaps, no irregularities the system would flag. I scrolled back through my notes from the night before, the ones where I described what I heard and didn't hear, what I felt and didn't feel. They were there, preserved, but they didn't change the conclusion. Death declared, case closed. By late afternoon, the room had been reset, fresh linens, new oxygen tubing, the smell of disinfectant replacing the faint scent of skin and lotion. Eleanor's presence erased with practiced efficiency. I stood in the doorway longer than necessary, staring at the bed. Samuel Crow's room had looked the same the morning after he died. 2 patients, 2 deaths. 2 bodies that hadn't followed the sequence I'd learned to trust. I went home that night exhausted in a way that sleep wouldn't fix. I replayed the pronouncement in my head, not because I thought it was wrong, but because it felt unfinished. When I came back for my next shift, there was a note from administration reminding staff to complete charts promptly to maintain workflow. A routine message. A reasonable request. I opened Eleanor's archived file one last time and read the cause of death again. It was accurate. It just didn't explain what my hands had felt, what my ears had missed, or why the body had refused to confirm the story as quickly as the paperwork had. I closed the chart and logged out, aware that something fundamental had shifted, not in Eleanor's care, in mine. I noticed the room was empty before anyone mentioned it. Room 12 had already been reset again by the time I walked past that afternoon. The bed was perfectly made. The call light cord lay neatly coiled on the rail. The whiteboard had been wiped clean, waiting for a new name to be written in dry erase marker. There was no trace that Samuel Crowe or Eleanor Whitman had ever occupied that space beyond what existed in the electronic record. Hospice moves quickly after death. It has to. Beds are limited. Families are waiting. Care doesn't pause for reflection. Still, the speed with which both cases disappeared unsettled me, not because it was wrong, but because it was effortless. At the nurse's station, I logged in and pulled up Eleanor's chart again. It was fully archived now, locked. Any edits would require formal reopening and administrative justification. The timestamps were immaculate. Pronouncement, notification, funeral home, discharge, every step accounted for. No red flags, no gaps. The system was satisfied. I scrolled through my own notes, reading them as if they'd been written by someone else. Objective language, careful phrasing, observations without conclusions. They were there, but buried among routine entries that carried more weight simply because they were familiar. Karen leaned against the counter beside me, lowering her voice. Family came by this morning, she said. Eleanor's... I asked. She nodded. They asked if they could see the room, not the body, just the room. I pictured it, standing where she'd been, looking for something to anchor the loss. What did you tell them? I asked. That it was already turned over, Karen said, which was true. I didn't ask how they reacted. I already knew. Families rarely argue with hospice staff. They're exhausted, grateful, focused on next steps. Later that day, I was called into a brief meeting with administration. Nothing formal, just a check-in, caseload, staffing, any concerns. Everything okay on your end? The administrator asked. Yes, I said. That was the correct answer. I considered mentioning the unusual findings, the absence of pulses, the delayed post-mortem changes, the quiet similarities between cases that shouldn't have been related. I imagined the response, a nod, a sympathetic expression, a reminder that hospice isn't about investigation. If there's no actionable change, there's no place to put the concern. So I said nothing. Back on the floor, a new patient was being admitted. Different diagnosis, different story. The routine resumed without hesitation. Nurses adjusted pillows. Families asked the same questions. The cadence of hospice life reasserted itself. I found myself watching the intake process more closely than usual. How quickly information was summarized. How decisively labels were applied. Terminal, comfort measures only, expected decline. Those words carry weight. They shape what you look for and what you stop looking for. I checked the schedule and saw that a night nurse had requested a different assignment for the coming week. No reason listed, just a preference. I knew why. That evening, Rachel caught me in the hallway. Do you ever feel like we're rushing the ending? She asked quietly. No, I said automatically. She studied my face. Sometimes it feels like we're finishing the story before the last sentence is written. I didn't respond, not because I disagreed, because I didn't know how to answer without undermining everything hospice stands for. Later, alone in the break room, I reviewed discharge summaries from the past quarter. Not all of them, just enough to see how consistently death was framed as a moment rather than a process. A timestamp, a checkbox, a transition point that allowed care to conclude. I understood the necessity. Medicine needs endpoints, systems need closure. But sitting there scrolling through completed charts, I felt a growing discomfort with how final those endpoints were treated. Once the paperwork is done, curiosity stops being useful. The following morning, a routine email went out reminding staff about documentation standards and the importance of timely chart completion to ensure continuity of care. It was well-intentioned. It also underscored something I hadn't wanted to admit. The system isn't designed to hold ambiguity. Anything that can't be categorized, measured, or acted upon gets smoothed out, not out of malice, but efficiency. Silver Willows wasn't hiding anything. It simply had no mechanism for lingering uncertainty. I went back into room 12 and stood there again, even though there was nothing left to see. I imagined Samuel's calm expression, Eleanor's quiet observations, the way both of them had spoken about dying as if it were something scheduled, negotiated, or slightly misaligned. I checked the corners of the room out of habit. The oxygen port, the monitor mount, everything exactly where it should be. When I left, I paused at the nurse's station and looked around at the staff moving through their routines. Competent, compassionate, focused. No one looked like they were missing something. And maybe they weren't. Maybe this was simply the cost of doing this kind of work. You accept the limits, you trust the structure, you let go of what doesn't fit. Except I couldn't. That afternoon, I caught myself hesitating before signing another death certificate. Not because the patient hadn't died, because I was acutely aware of how much meaning I was assigning to that signature. It wasn't just confirmation, it was permission for the system to forget. By the end of the shift, Eleanor Whitman and Samuel Crowe existed only as closed cases in a database. Their rooms were occupied by new patients with new stories already being summarized. I logged out of the system and sat there for a moment, hands resting on the keyboard, feeling the quiet pressure of a realization I hadn't yet named. The cases weren't unresolved. They were resolved too easily, and that ease was beginning to feel like a problem I could no longer ignore. I hesitated before reaching for the pen, aware of how often that hesitation had started to appear. The chart in front of me belonged to a different patient, different diagnosis, different family. Everything about it was straightforward. Comfort measures, expected decline. No surprises. The kind of case hospice is built to handle. I signed where I was supposed to sign and moved on, but the pause lingered in my body longer than it should have. Over the next few days, I noticed changes in myself that were subtle enough to be easy to dismiss. I stayed in rooms longer. I listened more carefully than necessary. I checked pulses I already knew would be difficult to feel. I reread notes I'd written the night before, looking for something I might have softened without realizing it. Karen noticed first. "You're hovering," she said one afternoon as we walked back from a family meeting. "I'm being thorough," I replied. She didn't argue. She just nodded in a way that suggested she understood more than I was saying. Sleep became unreliable. When I did manage to rest, I dreamed about monitors that never alarmed and hands that never found what they were trained to find. I woke up with the feeling that I'd forgotten something important, even when nothing specific came to mind. At work, the routine continued without interruption. Admissions came in, deaths were pronounced, families grieved. The machinery of hospice care did what it was designed to do. I did my job well enough that no one questioned my performance. That somehow made everything worse. I began to realize that the problem wasn't that the system had failed me. It was that it didn't need me to believe in it anymore. One evening, as I finished rounds, Rachel stopped me in the hallway. I requested fewer night shifts, she said. Why, I asked. She hesitated. I don't like how quiet it feels now. I knew what she meant. Night shifts had always been quiet, but this was different. The quiet wasn't peaceful anymore. It felt watchful. Later that week, I caught myself avoiding room 12 even though it had been occupied by 3 different patients since Eleanor left. The room itself had become neutral again, just walls and equipment. Still, my body reacted before my mind could reassure it. I started double-checking death pronouncements with unnecessary thoroughness. Longer listening, longer waiting, longer moments of uncertainty that didn't change outcomes but stretched them uncomfortably. Nurses noticed. No one complained. Take your time, Karen said once. There's no rush. There was always a rush. It just wasn't acknowledged out loud. I reviewed my own documentation habits and saw how much they'd changed. Where I used to summarize, I now described. Where I used to rely on defaults, I now spelled out what I'd observed and what I hadn't. It made my notes longer and less efficient. It also made them harder to ignore. Administration didn't say anything, but I could feel the shift. Efficiency matters. Predictability matters. Hospice depends on both. One afternoon, I found myself sitting in my car after a shift engine off, staring at the steering wheel. I wasn't tired in the usual way. I wasn't burned out. I wasn't overwhelmed by grief or workload. I was unsettled. I thought about Samuel Crow's calm expression, Eleanor Whitman's quiet certainty, the way both of them had spoken as if death were something slightly misaligned rather than imminent. I thought about how easily their cases had closed once the paperwork was complete. I wondered how many other cases I'd seen over the years that hadn't quite fit, but hadn't stayed with me long enough to matter. The thought made my chest tighten. Hospice medicine asks you to accept limits. It asks you to recognize when intervention causes more harm than good. I believed in that deeply. I still did. But acceptance requires trust, and trust depends on understanding what you're accepting. I was no longer sure I did. The moment that clarified, it wasn't dramatic. It didn't involve another patient behaving strangely or a monitor contradicting my hands. It happened during a routine meeting about staffing coverage. As the discussion turned to scheduling, I realized I was calculating how many nights I had left on the roster and how much relief I felt at the idea of fewer overnights. Not because of fatigue, but because I didn't want to be present for another moment where the rules quietly failed without acknowledgement. That realization sat heavily. Later, I spoke to the medical director about adjusting my schedule. I framed it carefully. Work-life balance, long-term sustainability. He nodded supportive, unaware of what I was actually asking for. Reducing my night shifts helped in some ways. It also confirmed something I hadn't wanted to face. Distance didn't make the unease go away. It just made it easier to ignore. I caught myself second-guessing decisions I'd never questioned before. Not clinical calls, but philosophical ones. When to intervene, when to observe, when to let the system carry the weight of uncertainty instead of me. The confidence that had once anchored my practice had eroded into something more fragile. I still knew what to do. I just didn't know what it meant anymore. One evening, while finishing notes, I stared at the blank space at the bottom of the chart where additional comments could go. I typed a sentence, deleted it, then typed another. Nothing felt appropriate. There was no place in the record for what I was actually thinking. That was when it became clear that this wasn't about two patients or a handful of strange observations. It was about whether I could continue working in a field that required me to treat uncertainty as noise instead of information. I closed the chart and logged out, aware that I was approaching a decision I hadn't consciously made yet but was already living with. The work hadn't changed. I folded the resignation letter once before putting it in the envelope, not because it needed folding, but because my hands needed something small and physical to do. It wasn't dramatic, no shaking, no tears, just a quiet recognition that the words on the page were already true by the time I typed them. I had tried adjusting my schedule, my habits, my expectations. None of it changed the way the work felt now. Hospice hadn't become harder, it had become narrower. I handed the envelope to the administrator during a routine check-in. He looked surprised, then concerned, then professional. He asked if I was burned out, if I needed time off, if something specific had happened. No, I said, nothing specific. That was true in the way most important truths are. Nothing specific, just something fundamental. I finished my remaining shifts as planned. I did my job carefully. I treated patients with the same attention and respect I always had. Families thanked me. Nurses relied on me. On the surface, nothing changed. Inside, everything had. I found myself listening differently. Not harder, not more intensely, but with an awareness that some sounds aren't meant to reassure. I noticed how often comfort was defined by the absence of visible distress rather than the presence of understanding. I noticed how easily we equated quiet with resolution. One afternoon, I stood at the bedside of a patient who was actively dying, watching the familiar signs unfold in the expected order. Breathing slowed, skin cooled, color shifted, everything matched the pattern I'd learned to trust. I felt relief, and that unsettled me more than confusion ever had. Relief meant predictability. Predictability meant the system knew how to respond. I thought about Samuel Crowe and Eleanor Whitman, about how their bodies had refused to follow the script without ever creating an emergency, about how they hadn't asked for intervention or answers. They had simply existed in a space medicine wasn't designed to describe. I didn't believe they were miracles or anomalies in the sensational sense. I didn't think they were anything other than human. That was the problem. If they were human, then what I'd seen belonged somewhere within medicine's understanding, even if we didn't know where yet. Hospice didn't have room for that question. It wasn't built to explore edge cases or investigate physiology that didn't demand action. It was built to provide care within accepted boundaries and to close the story when the body stopped responding. That design works most of the time. It just didn't work for me anymore. On my last night shift, I walked the halls more slowly than usual. I checked in with nurses, thanked them, said things that sounded like routine farewells, even though I hadn't announced anything publicly. The unit looked the same as it always had. Soft lights, quiet monitors, a place designed to feel calm. I stopped outside room 12 without realizing I was doing it. The door was open. A new patient rested inside, breathing evenly. Different face, different story, same setting. I didn't go in. I stood there and acknowledged something I'd been resisting since the beginning. Medicine isn't wrong when it simplifies. It's incomplete. Those aren't the same thing. Simplification is necessary to function. But when simplification becomes the only acceptable framework, anything that doesn't fit gets smoothed away. I had smoothed things away myself for years, not out of neglect, but necessity. You can't question every death. You can't investigate every inconsistency. You have to trust the structure, or the work becomes impossible. The problem was that I could no longer pretend the structure was neutral. In the weeks after I left Silver Willows, I took a temporary position in a clinic. Short visits, clear problems, defined outcomes. It was easier. It was also quieter in a different way. The kind of quiet that comes from staying within boundaries everyone agrees on. Sometimes when I listen to a patient's heart now, I pause longer than necessary, not because I expect silence, but because I'm aware of how much meaning we assign to the sounds we're trained to hear. I still believe in medicine. I believe in its ability to reduce suffering, to guide decisions, to help people navigate uncertainty. I don't believe it understands death as well as it thinks it does. Death isn't always a moment. It's often a process, one that doesn't announce itself clearly or adhere to timelines we find comforting. Sometimes the body lets go in stages that don't align with our checklists. Sometimes the signs we rely on arrive late or out of order. Those moments don't demand panic. They demand humility. I think about the number of cases that have passed through hospitals and hospices without comment because nothing actionable was missing. I think about how many clinicians have noticed small inconsistencies and decided correctly that raising them wouldn't change anything. That doesn't make them wrong. It makes them human within a system that values closure. I don't regret my years in hospice. I learned how to sit with people at the end of their lives. I learned how to listen when words ran out. I learned that comfort isn't always about fixing. What I didn't expect to learn was how uncomfortable it would feel to realize that some endings don't want to be finalized on our terms. When people ask why I left, I give a simple answer. It's easier, less alarming. It fits the story people expect. What I don't say is that I left because I couldn't keep signing off on explanations that felt finished when the experience wasn't. I couldn't keep pretending that silence always meant resolution. There are things medicine can't cure. That's something we accept early. What's harder to accept is that there are things medicine can't fully explain, not because they're supernatural or mysterious in a dramatic sense, but because they exist in spaces our systems aren't built to explore. I don't know what Samuel Crow's body was doing in those final hours. I don't know why Eleanor Whitman's heart refused to make itself heard while her circulation continued to behave as if nothing was wrong. I don't need those answers to know that what I witnessed mattered, not as proof of anything extraordinary, but as a reminder that human biology is broader than our definitions and death is more complex than our forms. That knowledge didn't make me afraid. It made me honest, and once that happened, continuing as if nothing had changed was no longer an option. I don't tell this story to suggest that hospitals are broken or that doctors and nurses don't know what they're doing. I spent most of my adult life inside hospital rooms and hospice halls working alongside people who care deeply and do their jobs well under impossible pressure. This story isn't about failure, it's about limits. Working in medicine teaches you how much we can do. It also teaches you slowly and quietly how much we can't. Most of the time, those limits don't bother us because the system keeps moving. Charts close, shifts change, new patients arrive. But once in a while, a case stays with you, not because it was dramatic, but because it didn't fit neatly into the rules you've been trained to trust. What I learned from this experience is that not every truth comes with an explanation that feels complete. Sometimes the most honest thing a doctor can say is, "I don't fully understand this," even when everything looks correct on paper. And sometimes the hardest part of being in healthcare isn't the loss itself, but realizing how easily uncertainty gets smoothed over so the work can continue. If you've worked in a hospital or spent time around doctors and nurses, you've probably seen moments like this. Small details that don't quite add up, stories that never make it into official reports, quiet experiences that stay with you long after the shift ends. Those moments don't make medicine weaker. They remind us that it's human. If stories like this resonate with you, especially real-life hospital experiences and doctors and nurses' stories that don't have easy answers, consider subscribing to the channel. I share these stories not to shock, but to reflect on the parts of medicine we don't talk about enough. The quiet ones, the uncomfortable ones, the ones that linger. Thanks for listening.